So we all know that pathological myopia has a high disease burden, and myopic foveoschisis occurs in about 30 to 40% of the patients having more than 8 diopters of myopia. And excessive axial elongation results in mechanical stretching, leading to staphylomas, RP atrophy, lacquer cracks, hemorrhages, CNVMs, myopic foveoschisis, and finally myopic macular hole with posterior pole fluid. So I'll be discussing the surgical, intricacies of these difficult cases, and there are a few points which are unique to these eyes, these long eyes. These are complex cases. So visualization, length of the eyeball is a problem. PVD induction is difficult as compared to adult detachments or adult macular holes, and a final common algorithm or a technique which can yield consistent results. So coming to the first thing, visualization. So even my threshold for doing a phaco-vitrectomy either in the first stage or in as a stage procedure or as a combined procedure is very less, because even a small amount of lenticular opacity in these patients creates a lot of spherical aberrations. So it's always a good idea to go for a IOL and then do the peeling, because anyways the contrast is very low, and it's very difficult to see the ILM under that bad contrast. So if you have an intraocular lens in place, it makes your life very easy. You might get away with a dense cataract in routine ERMs and macular holes, but not in these cases. The second point is length. Of course, we all know that we make 4.5 or 4 posterior ports, or we remove the trocars. But just to highlight that if the axial length is more than 30 and they are very long eyes, actually if you are using a non-contact system, your forceps is practically vertical and the shaft touches the rim of the non-contact system. So it's a good idea to use a Lander's lens or a macular lens, a irrigating lens, because they give you excellent magnification, they give you excellent resolution, and the problem of touching of the forceps to the rim of the non-contact wide-angle system is not there. Of course, there are many other ways also. You can use customized instruments. Here I am peeling from my left hand because from the right hand I could not reach the fovea. Unfortunately, the detachment, the posterior pole fluid was more temporally. So you can all use customize all these things to actually reach the posterior pole and do good peeling. The third point is PVD induction. So again, I'll divide all these surgeries into two parts. The first is where the axial length is manageable. It is around 27 or 28, and here you can, again, practically all these cases have vitreochasis. So you have to restrain, and you'll find that thin layer of hyaloid. So you inject a small amount of hyaloid. This is what we are using for past many years. You make, you use a end gripping forceps. You make a small hole in the hyaloid. You try to enlarge it, and once it is enlarged, you just do a blunt dissection with a light pipe, so the PFCL gets into that hyaloid, into the subhyaloid space, and you can refill that space with PFCL, atraumatically inducing the PVD till the equator, and it's a very reproducible and a safe technique to do that. And once that is done, you can carry out your routine maneuvers. But this technique does not work in patients who have very high axial length of more than 30 mm. Actually, it will increase the axial length more if you inject PFCL, and you are practically will be impossible to reach the macula. Here there is no shortcuts. You have to grasp and re-grasp with the forceps, with cutters. You can see only I can hold it only by the tip. So it takes a lot of patience, and you have to do multiple staining and multiple attempts to remove the hyaloid. And there are no shortcuts, and no PFCL works in this case. But despite making posterior ports, restaining, doing adequate peeling, there are failures because there are many caveats in the management which we actually overlook. And if we leave the hyaloid in place, or if we don't do a proper peeling, this is what happens. And there are recurrences, there are late reopening of holes. So I'll tell you a few examples of what we do and what is our common algorithm, what we follow. So again, dividing it into two segments. First is where the contrast is, not that bad, and you can see the ILM. And again, making ports beyond 4 mm, inducing the PVD. This is a myopic macular hole with posterior pole fluid, staining and restaining and removing the vitreochaetic layer also. Now finally the posterior pole is clear, and we stain it with blue G and keep it for a little more time than what we actually keep it in routine macular holes. Then injecting a small bubble of PFCL at the posterior pole. Can I have the lights off, please?
लाइट्स ऑफ कर दो.
And then
Put
you
up the
do,
light, please.
grasp the ILM and do an inverted ILM peeling towards the hole. Now here there are 2 points. First is, the peeling should be towards the hole, and the second, you have to have a wide area of peel actually approaching the curvature of the staphyloma, because if you don't do that, the retina won't be, pliable enough to close the macular hole. It might close in the initial post-op period, but there will be there are high chances that there will be late reopening of the hole. So you inject a small bubble of PFCL. So the elegance of this, of this technique is that there is so much fluid, and you can see that fluid being displaced by the PFO in the periphery. You don't need a second retinotomy to drain that. And in the post-op period, in a couple of days, that fluid will absorb. So you can see that blue dot, the flap under the PFCL, that is stable. That will be stable after aspiration of the PFO bubble also. And this case is closed under gas tamponade, and the patient, generally does fine. So, but this is another scenario where the contrast is better, and actually you cannot see the hole under PFCL, and that acts as a deterrent to peeling. So here you should not use this heavy liquid. So I have aspirated the PFCL, and now you see how beautiful the contrast is. So just to exemplify this, this is again a ICL macular hole posterior pole fluid case, and again the ports are very posterior, you can see, and the patient had axial length of 32. You can see the posterior staphyloma and the poor contrast, and after, induction of the PVD and doing rest of the other maneuvers, now you inject, and now the PSCL has not been injected. So if you inject the PSCL, you will be barely able to see the macular hole, let alone the flaps. So you do the ILM peeling. The first pinch is a little crucial and tricky, but once you get hold of the fold and the contrast, then you can peel it very easily, and you make multiple flaps, and do not complete the peeling. Just move the flaps towards the edge of the hole, and once adequate flaps are there, then you inject your PFCL, just to reposition them inside the hole, and you keep that PFCL over the flaps for a couple of minutes, and then you go under air. Now what happens is, again you have that blue dot which I showed you in the previous case. The flaps are in position. They will not displace when you aspirate the heavy liquid, and this technique works beautifully. That is the sequence of peeling first and injecting PFCL afterwards in eyes where there are very, poor contrast. And if the contrast is good and you can see the ILM, you can directly do the peeling under PFCL also. So these are the post-op results of the cases I have shown you. And just to conclude, these are complex surgeries with varied intraoperative surprises. A thorough preoperative workup and planning is needed. And these are the key to success: combined procedure, adequate PVD induction, multiple staining, longer staining, posterior ports, and of course a thorough preoperative counseling is very important about the chances of failure, suboptimal vision recovery, and late reopening of holes. Thank you so much.
No, 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 तुम बोलो. Excellent talk, Dr. Vishal, as usual. So my concern is when the in macular myopic tractional maculopathies, the macular hole with detachment comes in the as a last stage, final stage of
Yeah,
the
this is the extreme,
whole extreme
classification of the
situations.
Barbara
Yes.
classification.
Are you using any kind of macular
Macular
buckle?
buckle? No, I have
Yes.
not used it. I have
You are not.
experienced, yes.
But androsplum and any other L-Cepate, T-Cepate, all kind of buckles are available
Yeah.
nowadays.
What is your experience about the myopic?
No, no, I have not done it till now.
Dr. Srinivas, you have used, I think, in a couple of cases recently.
Yes, I have used the Barbera Parolini buckle.
Yeah.
It works really well, especially when you have a staphyloma with macular hole, and only ILM peeling might not suffice.
Okay.
So in those cases, it really helps, or especially in myopic Foveoschisis, very large Foveoschisis.
So you combine it with vitrectomy or just a buckle?
The first procedure I always do is external procedure. Try to do without vitrectomy if possible. Of course, macular hole, then you have to go inside, but no macular hole, just a VMT or a Foveoschisis. I first usually try with especially the stage 4, what she has described. We try to do it with a buckle. If not, then always you have an opportunity to go in, because the buckle stays for long. The advantage of that buckle is it's illuminated, and we can use our own chandelier lights. You need not, because it's expensive. The only drawback of this is it's cost around 85 to 90,000 rupees.
Yeah.
That's the only drawback of that.
And are your follow-ups long enough to comment on the atrophy part?
No. I have I think 3 to 4 months of experience now in 2 buckles, but I don't have very long follow-ups.
Yeah, Vishal, just one comment rather.
Yeah.
Very nice, excellent presentation. So see, when you put PFCL, the contrast reduces because the retina gets attached.
Dramatically.
And if there is a retinal detachment, you can stain with the dye. But if you don't have a, if you have a macular hole without RD in such cases, then I just want to
Macular
suggest,
without RD.
yeah, in
Yeah.
such in with such cases which are pathological myopia, I think staining
So I have
with
injected with BSS also there with a 41 gauge cannula. What I'm trying to tell you is on a detached retina, it's very easy to peel the
yeah,
retina
so
when
I
the
just
contrast is very poor.
so you can stain it with triamcinolone. I think rather than staining it with brilliant blue, triamcinolone does a good work. I've done few cases with triamcinolone,
In
and you are
Myopic macular holes.
yeah,
Okay.
pathological, yeah, because with ILM, with triamcinolone, you know, when you just peel the ILM, then the crystals they tend to move out, so the peeling becomes slightly, the staining becomes slightly better with triamcinolone in such cases.
Okay.
If there is attached retina.
I'll try that.
Thank you so much,